Introduce the last speaker of this session. So Dr. GANESAN, who's going to talk about masquerade syndromes. We're doing quite well for time, so no need to rush to.
Yeah. So I would like to, begin with this slide. When we say it's on a lighter model, so you see two images. So can anybody guess what is each animal here? So one is a lion, the other one I will allow you to keep guessing. So with that, a warm good afternoon to all of you here, and I would like to thank the AIOS and the APO and the WAS for giving me an opportunity. So I'm going to be talking about unmasking the masquerade syndromes. So a little bit, my topic's a little deviation from what the other speakers spoke. So here is a lady who's a 17-year-old young girl with 6/24 vision. She comes with pyrexia of unknown origin. So you can see here she has a lot of exudates in the vitreous. So when you see such a patient who comes to you with fever, so what would be your first line of thinking? So we all tend to think so much of exudation, and you can see the ultrasound what is happening. So with a fever which is there for at least 12 days, so your thought process is, am I dealing with an endophthalmitis? That would be the first line of thinking. So what did this girl have? This girl, when I did the vitreous, so of course, before that, I had already worked up this patient because I'm an oncologist, so my line of thinking would be a little different from the other way of approaching. So I knew very well what I'm dealing with. So what was she having? She was having an immunohistochemistry that is positive for a neuron-specific enolase, and she also had the retinoblastoma protein positive, the synaptophysin positive. So what was negative? It was the HMB that was negative. And of course, so when we know now what we are dealing with, this condition is an adolescent onset retinoblastoma. So when you see an eye that is quiet, and though there is a history of fever, do not get carried away. And if your ultrasound is not revealing calcium, not all the time you may get on that also. So this is something which you should keep in mind. Now, in the literature, how many cases do we have? So basically, if you see, not more than 30 cases are there till date on adolescent onset retinoblastoma. So next is a 26-year-old male patient who comes to you with 1/60 vision in intraocular pressure of 16 millimeter of mercury. The blurred vision is for 4 months, and when you can see on the picture here, you can see a pigmented mass that is there with the detachment in the eye. So when we did her MRI of this particular patient, so what it did show, it was low signal on 2 weighted images and a post-contrast enhancement was homogeneous. So the suspicion is high on a melanoma. So now with a melanoma, the usual practice for these kind of patients are what? Because the size is 11.5 millimeters. So then you tend to think, okay, now I'm having a melanoma. The options for these patients would be to give what? To give either a proton beam therapy or to give a plaque brachytherapy. So what did I do instead? So I thought, because from the ultrasound, to me, it did not look like the melanoma, so I decided to resect the tumor. So what was inside? So this was a patient who is having a whitish lesion. So it was pigmented on the outside, but when you see inside, this is a white colored mass. So what is this? This is called as, now when you go through the immunohistochemistry, and of course when you see the lesion, which is white in color, pigmented only on the surface, so this is a leiomyoma. So leiomyoma, which is supposed to be Desmin positive, the Vimentin positive, Calponin positive. So here is the confirmation that it is there. And when you see on the histopathology, it is a lower nuclear cytoplasmic ratio. So when the NCA ratio is very less, you know you're not dealing with any malignancy. So now what is a leiomyoma? It is a smooth muscle tumor of the uveal tract, predilection to females, and it affects the ciliary body and the peripheral choroid. So the treatment is endoresection or the sclerouvectomy. So it's not life-threatening. So this patient was referred for the management of melanoma when the whole family was like sinking in the thought that they're going to be having a tumor. But then, giving the diagnosis that no, you're not going to be dying, rather you're going to be living more than anybody else, is something which you are going to be giving. So what is the difference between a leiomyoma and a melanoma? Leiomyoma occurs in the supraciliary or the suprachoroidal space, whereas a melanoma is coming from the uveal stroma. And the most brilliant clue is the transillumination. So if you can pick up the transillumination, you can hit on the diagnosis of a leiomyoma very well. So moving on to the next patient, she's a 65-year-old female with a vision of hand movements, intraocular pressure being normal, yet again a pigmented mass lesion. So the current thought process is what? It is like hyper on T1, hypo on T2. So very characteristic, even on an ultrasound, if you see the surface reflectivity and the internal reflectivity, you can almost think, it's very solid, so possibility of a melanoma is very high. But then what exactly is it? When we did the tumor biopsy of this particular patient, it revealed plasmacytoid cells. So the plasmacytoid cells, what does it account to? So we did the hematological workup. So the CRAP criteria is to be followed, because when you deal with plasmacytoid cells, so your thought process should be in terms of a multiple myeloma. So here you do all the CRAP workup and the biomarkers. And then what do you see here? This patient belonged to what is called as the solitary plasmacytoma, which is only present in 7% of the individual. But very commonly when you tend to see a plasmacytoma, extramedullary plasmacytoma, be very vigilant, run a good workup for the multiple myeloma, because these clonal proliferations, tend to get differentiated. So the treatment for these kind of patients are like to give a radiation therapy. So when I gave a cyberknife therapy, because did not want to go into the IMRT, because that could be more toxic in these patients, and these are not very aggressive forms, so cyberknife is more sufficient. So here is a 25-year-old female, 6/18 vision. Again, the MRI is hypo on T1 and T2, referred as melanoma with, of course, the exudative retinal detachment, which is there. The height of the tumor is more than the base, fitting into perfectly a melanoma. But what is it? When you do the biopsy, it turns out to be melanocytoma. So melanocytoma is again not aggressive disease, it is a benign lesion. So a patient would never die of a melanocytoma. So the crucial role is, once it's very important, that not all pigmented lesions are melanoma. That is what is a common myth people tend to think. So now, I did a biopsy of this patient, of course settled the retina also. You can see the pigment dispersion, because she was a girl from Ethiopia. So you can see a lot of, in these pigmented rays, the dispersion will be very high, So this is 3 years later, she was 6'9", N/6, with no subretinal fluid even at 3 years. So she was a PhD student, and was going to be married. And the mother was almost in tears when she came all the way from Ethiopia to India, and thinking that her daughter would die because the diagnosis was a melanoma. Then we broke the news that, no, it's not a melanoma, it's a melanocytoma, so it's not going to be any life-threatening disease. Now we move on into a 5-year-old female who is 6/18 N6 vision, and you can see the tiny little thing on the infratemporal border of the eye. So this is the root of iris invasion, and you also see what is happening from the ciliary body. So this is a ciliochoroidal lesion. So yet again with a base of 11 millimeters and a height of 11 millimeters, hyper on T1 and hypo on T2. So this yet again on your MRI would be reported as melanoma. So when these kind of things come, that is because of the solidarity of the tumors. On bleach preparation, you tend to see the epithelioid cells. So this is one more thing of not a melanoma, a melanocytoma. So this is another patient who just came in with a PL positive vision with projection, of course, deficient in 2 quadrants. She had renal cell carcinoma. So this was referred to me as a metastasis, choroidal metastasis. So yes, this was the picture which we saw on ultrasound, a very globular lesion anteriorly located. So of course, when we did the MRI and the whole body PET CT scan, there was nothing else apart from what is the involvement in the eye, intermediate signal on T1 and hypo on T2. So this again was diagnosed as a choroidal metastasis. So what did we see? we saw a leiomyoma, which was inside. So now your whole staging differs. When you have a patient who's got a renal cell carcinoma with a choroidal mets, so obviously the treatment pattern is different. But when you do the biopsy and you prove that it is not anything connected with that cell carcinoma itself, and local resection has worked, and this is a benign lesion which is sitting in the eye. So this, you should never get carried away by when a patient gives you a history of carcinoma and then connect it with what is in the eye rather than proving without a histopathology. So this is a 48-year-old female, again with flashes of light, 6x6 N6, with history of rheumatic fever, and of course on penicillin prophylaxis. So now what is the diagnosis from here? Now that I've shown so many pigmented lesions, so what do you think this should be? Is it benign or malignant? So I did a brachytherapy. This is pre-brachytherapy, and then a month later, 7 months later. So you see, this lesion did not respond. It's consistently growing. What do you see here? So this is a melanoma. So this was quite in the beginning of my career when my understanding on the biopsy was not there great. So what did the patient go through? A mixed cell melanoma, extensive necrosis, episcleral extension, monosomy positive, orbital accentration had to be done to save this patient. So all pigmented lesions need not be melanoma, but a melanoma should never be missed either. So what are the differentials when you have pigmented lesions? Melanoma, metastatic tumors, nevus, neurofibroma, schwannoma, hemangiopericytoma, choroidal meningioma, adenoma of the ciliary epithelium, medulloepithelioma, medullocytoma, so melanocytoma. So all these things are something that is to be kept in mind when we see these lesions. So the simple message to carry is MRI is not the diagnostic modality in pigmented lesions of the choroid. Tissue biopsy is mandatory. Adequate sample is necessary. Otherwise, when you just send a few samples to the histopathologist, he will say that he will give you a report stating that inconclusive. So when it comes inconclusive, you are in the middle of nowhere. Histopathology is again to be supported by immunohistochemistry. Comorbid conditions may arise later. Systemic surveillance is of utmost importance. That is the key buzzword here. So now the answer to the question of what is the other animal that was there, which is not a lion, so it is a Tibetan Mastiff. So with that, I would thank the audience for giving me an opportunity to share my thought process here, and I thank my colleagues in my institute who have been supportive to, in referring the patients to me on time and having belief in me that I can do the job. Thank you.
Thank you so much, and all the speakers have kept to time very well. So now we have about 10 minutes for questions. So do we have any questions from the floor? Any questions? So
very interesting topic. There must be some question. Anybody?
I think if no one from the floor yet, may I ask the first question? So maybe just following from Dr. Ganeshan's talk, this is quite a. These are quite rare tumors and very scary for us, for most of us. Do you now biopsy all of these lesions, or do you only pick some of them? Because you mentioned that you biopsy the pigmented lesions. What about the non-pigmented lesions, which you suspect are metastases?
My talk simple, I had put down all the pigmented lesions together. Of course, the lesions that are not pigmented, that are even more challenging because it will be amelanotic lesions. So amelanotic lesions also, see, like you must differentiate between whether you're dealing with an infection, whether you're dealing with an inflammation, or whether you're dealing with a neoplasia. So these are the three categories under which you would like to categorize your patient. But if you are like in a country like India, where the tuberculosis is very predominant, so that would stand up on the line of treatment first. So before we do a biopsy, all these patients do a complete whole body screening. So we kind of rule out whether are we dealing with infection, which infection means the first thing would be tuberculosis. So if anything coming from the choroid, are we having a granuloma, whether it is a tuberculous granuloma, whether it is a sarcoid granuloma when it comes to amelanotic lesions, or it is an amelanotic melanoma. So this is also there. So first would be a full body screening. Once we know that we are not having any other clues to the diagnosis, that is when the biopsy is attempted. But when I have high on suspicion, even if it is a melanoma, even before I do the brachytherapy, I do take the sample for biopsy. That the reason for biopsy becomes different. One is you would like to understand whether you're dealing with a type 1 melanoma or a type 2 melanoma, because yet again you have to tell your patient that it is malignant, but how is the systemic surveillance going to be? So if it is not the aggressive form of melanoma, because in India the aggressive form of melanoma is very less. So the Western countries, the non-aggressive is very less, aggressive is more for them. So their death due to melanoma is more than our deaths due to melanoma. So when you have to talk to your patient, they always look at, I'm having a cancer, am I going to live for long or no? That answer is something which you should give. So because of that reasons, I do the biopsy and then I classify it, and then if we have to break the good news, they're more than happy, or if we have to break the bad news, that how are we going to keep them on follow-up. So in that situations we always tell them. So for that reason, yet again biopsy is very helpful. But in granulomas, not all the time biopsy is required. So in these things, what is the most important thing is the ultrasound should be done by yourself. So that is most important. You do the ultrasound, and then your MRI person has to be really good in understanding that, and they should tell you how they see the reflectivity on the MRI. So yeah, but not all patients I do a biopsy. The workup has to be done completely. That is most important before we err on the side of doing the biopsy.
What type of biopsy you prefer?
See, there are two ways of doing a biopsy. You could, if they are peripheral tumors, I would do a transscleral biopsy. If it is a tumor that is posterior, then the transvitreal approach is being done. But along with it, if I feel it's a malignant one, then I do the resection, endoresection also. Yeah, so endoresection for the benign ones, and if I am having a malignant tumor, then I do sandwich therapy, in the sense that you do a pre-radiated, then you do the resection, then post-radiated. So like that we follow a sandwich regime of treatment, if the patient is not willing for a proton beam therapy for cost reasons. Proton beam becomes very costly, but that's still available in Chennai, so it's not a big issue, but yes. An aggressive form of tumors, we do that.
Right. You mentioned whole body screening. Would you do PET CT or and all the blood tests? Or
Yeah, so along with the blood test panel of investigations, I would do a whole body PET CT, whether that is, if you're thinking in terms of an infection thing, then that panel is different from the malignant panel. So either one, whichever you feel that is high on your priority, you would advise that.